I know that all of you having great time chatting with each other, and it's good to see all of you really enjoying your meeting today. So I'm Mona Fouad. I'm the director of the Minority Health and Health Equity Research Center, and I just want to welcome you to our 16th annual meeting. I can't believe that, but I know that since 2000, our last one in person was in 2019. So we had about 3 years of some virtual and just one lecture, and we didn't get to do what we used to do like every year. But I'm so glad today I saw the poster session, and I want to thank everyone that participated, all our postdoc and junior faculty. It was really a great posters, and you put time in putting this together. And then also after that, we followed with really 2 robust breakout sessions, and there were a lot of great ideas there that was presented. And you do know that we had judges in both the poster session and the presentations breakout sessions, but we're going to tally all this, and next week we're going to send an email and post the results on our website. So I'll say congratulations in advance to those that they probably already are winners. So I also wanted to thank all our judges that they helped us during the poster session, and thank Dr. Maria Pizzo and Apender Manning for moderating our presentation breakout sessions. So as you know, this symposium is sponsored by the University-wide Center, the Minority Health and Health Equity Research Center, and also by our NIH Center of Excellence, the Obesity Health Disparity Research Center. And I just want to thank everybody that participated today. We have representation from 8 states, so that's remarkable today. So we're going to start by this year, or actually 22, we celebrated 20 years of our center, and we developed a short video, and I thought maybe we can show you that before we get our keynote presentation today. So just going to take about 3 minutes.
There have long been big differences in health across race, income, education, and geographic location. These differences are even worse in our state and our region. In the early 2000s, a group of researchers at UAB saw things differently, that there was more to health than biology and personal choices, a notion that would be made apparent on a bus ride through the Mississippi Delta.
Mona and I had received a grant from the National Cancer Institute to address disparities in breast and cervical cancer in the Black Belt of Alabama and the Delta of Mississippi. And we were struck by the poverty levels, the distances between healthcare services.
We felt like, how are we going to tell a woman, go and get a mammogram? Is this a priority? She lives in poverty. She doesn't have transportation. But also she may have other conditions in addition to getting a mammogram. For us just to go tell her, leave everything and find the transportation to get a mammogram, I felt like this is unethical.
What became clear was the need for a comprehensive approach to understand the science of health disparities and the recognition that where a person lives, the condition of their neighborhood, and their access to health, education, and economic opportunities were vitally important to health. To address such disparities, we needed to learn more. The UAB Minority Health and Health Disparities Research Center was established to conduct research and develop the partnerships needed to eliminate health inequities. And Alabama was the perfect setting.
The origins of the MHRC were really tied to people who'd had a commitment to dealing with the obvious healthcare disparities that existed in our area. And we lived in, if you would, the heart of many challenged communities. And that was a sincere understanding that leaders would have to be transparent, committed, and engaging with those communities to build trust.
If the problem is in the community, the solution is in the community.
This innovative approach caught the eye of the National Institute on Minority Health and Health Disparities. Shortly after, the MHRC received the first Centers of Excellence grant in what would become 20 years of continuous NIH funding to study and mitigate health disparities.
It solidified the role of the center, both in the culture of UAB, the state, the Deep South, and arguably the country.
For 2 decades, the MHRC has been at the forefront of minority health and health disparities research nationwide, generating over $165 million from NIH and CDC-funded projects in Alabama, Mississippi, and Louisiana. The MHRC has also helped break new ground in health disparities research, providing nearly $7 million in funding to 146 scientists for innovative pilot projects. The kind of discovery and change MHRC researchers bring to underserved communities is priceless. As such, the thoughtful development of training and education programs for future generations is critical in the continued success of the MHRC.
We wanted the patients and the populations and people in the community can see people that look like them, that they're addressing their issues and challenges. And that's when we focused on our training program with partnerships with historically Black colleges to attract those undergraduate students and equip them with the knowledge and with the training so they can be competitive to get in health sciences.
While research and training is a big part of what we do at the MHRC, the community is at the heart of it. They are why we do it.
We move at the speed of trust. We really work on establishing and maintaining relationships. It is a series of going back and being there, being available, picking up the phone and calling just to check in. It really is not magic that we've been able to identify such wonderful partners, but it's that we have had these relationships for perhaps 2 to 5 years, and we've been there. The MHRC has been there and has always been there.
The MHRC has been remarkable, but we're not done.
The further maturation of the Minority Health and Research Center has been one from moving from disparities to health equity. But also, I think Live Hef Smart is really also the further defining of the MHRC to really step out and lead and collaborate to impact our entire state.
As the UAB Minority Health and Health Equity Research Center looks to the future, we will take key learnings from the past 20 years and turn them into practical efforts to achieve health equity. As the MHERC embarks on our next phase, we and our community partners will work together to ensure that a person's address and circumstances don't determine their ability to live a healthy, productive life. The UAB Minority Health and Health Equity Research Center, making health equity a reality.
Thank you. So now I just want to introduce a friend and a colleague, and I'm going to say a mentor too, because all what you saw here, I learned the principle of all this from Dr. Wayne Giles. You know, when I worked with him on Reach 2010 CDC project, he really developed the concept of community-based participatory research in action, and the implementations, and really the principles and the foundations. You know, what I learned from him really got us to develop all these next projects, because he gave us the foundation of how to do that. So this was the seed that he got here, and I hope you see the results of your mentoring and your work. So Dr. Wayne Giles now, he left CDC and he's now the Dean of the School of Public Health at University of Illinois, Chicago. And as I mentioned, he spent about 25 years leading the Centers for Disease Control and Prevention, where he led the division for heart disease and stroke and prevention, division of population health, and division of adult and community health. And that's what gave him the platform for all this work that he developed, a lot of programmatics similar to what we do. And he has a long career, like he moved from Baltimore to Maryland, St. Louis, Missouri, and then Atlanta, Georgia. And actually he has some roots here in Birmingham too. So in his early career, he trained in Birmingham. And we're so happy that you are back. And he's going to help us to also lead us in this vision for us that we're saying, the vision to make health equity a reality. Thank you, Dr. Giles.
Thank you. Good afternoon, everyone, and it's a pleasure to be here, and it's a pleasure to be back in Birmingham. As Mona said, I was in, I shouldn't say this because it will date me, but I was here from 1987 to 1990. So probably the majority of you weren't even alive when I was here in Birmingham. But I enjoyed my time in Birmingham largely because in many ways it sets the foundation. It was because of what I saw with the patients that I was taking care of that led me to do more work around prevention and public health. And so for that, I'm always grateful for the time I spent here in Birmingham, because it really, when I think about a lot of the early research projects that I was involved in, I think in terms of sort of how we did our projects at CDC, a lot of it was grounded in learning that I had here at UAB. The other thing, Mona said she learned a lot from me, but the reality is I learned a lot from Mona. And all of the investigators who were part of this amazing journey about REACH. And so it's really exciting sort of to see the work and see what that initial seed in REACH did as things grow. So my communications folks always say, when you talk, you always have to do a little bit about the School of Public Health at UIC. So this is the building. We're in an old psychiatric hospital. We have 7-degree programs, both undergraduate and graduate. We are a land grant university, of course, so the majority of our students come from Illinois. But one of the things I am so proud of is the diversity in our school. And so 14% of our students are Black and 18% are Latinx. I will also mention we just got a major grant from HRSA that will allow us to expand our number of underrepresented students. But really excited as we look and sort of rebuild the public health workforce back. What I thought I would talk about, and I love the video that went ahead of me, because I do want to reemphasize a couple of things in the video. And also, I listened to both the poster presenters who all did like an amazing job, and also the two sessions. And I really want to re-emphasize some of the messages that I heard there about the importance of place. So I want to talk about disaggregation of data. And while I think it's important, want to address some of the underlying factors and talk about trauma. Spend a little bit of time talking about community interventions and the journey and the philosophy around REACH. And then I'm going to end talking about sort of what I'm currently working on, which is providing data to communities in a really hyper-local context. And I'll get through that in about the next 40 minutes or so. So I'm going to talk first about place. And when I do that, I'm also going to talk a little bit about my history, because I think it grounds what we do. And so these are my parents, and I'm the one with the bony knee sort of in the center of the picture here. But my father got a job at GE, General Electric, outside of Philadelphia in a place called Valley Forge. You may have heard of Valley Forge. And they were looking for a house. And the reason I tell this story, because it shows informal and formal policies, and how informal and formal policies can exacerbate disparities, but also alleviate disparities. And so they were looking for a house, and they got a real estate agent, and the real estate agent took them out to see houses. And they noted that agent only took them to houses in certain areas. And they were like, well, what about houses over here, over there? And they couldn't get anywhere. And they befriended a local minister who was white. And the minister and his wife went out to the agent, went out to the real estate agent, and were shown houses in another set of community. And then there was a fair housing law that passed. And so my parents were able to then go to the real estate agent and say, listen, we heard there's a house in this community over here. We want to see that. And that sort of led to sort of where we were, and the importance of one. I think in some ways my parents had a little coalition that was going on there, but sort of had a really nice impact was there as well. I also am going to show this woman again, who was my mother. She was in the other picture as well. And she died at age 44 from a heart attack. She had diabetes, was overweight, with a little bit of arthritis as well. And so when I remember when she passed, I was 18 at the time. And I thought, someone 44, African-American woman dying from heart disease, that's an anomaly. But as I'll show you later on, it's not really an anomaly. It's something we all need to be concerned about. So just some early impressions of me that I think are important as we talk this afternoon. This is one of my favorite artists, is Jacob Lawrence. And he has a whole series of paintings that he does that are focused. Thank you for doing that. Yeah, it's hard to see this with the colors. But he has a whole series of photos, of paintings that he does of the Great Migration. And this is when African Americans, largely in the Deep South, during the 1910s, 20s, and 30s, moved to places like Chicago, New York, and St. Louis. And there was this huge migration. And I think it's important because when I think about this country, in many ways, we are a country of migration and where people move over time. And I think you can think about sort of what happened with Black folks and sort of their migration. And as we think about migration, we can think about the factors that might push people to move. So it might be racism, poverty, et cetera. But there may be factors that pull people to move in different areas as well. And all that's part of it. But I would argue, as we think about this country, we're all different populations that have moved and migrated over time. So you can think about the Irish, Italians coming in, thinking about Asian communities coming to this country. But you can also think about tribal communities as well, right? And so they were forced to migrate through the Trail of Tears from the southeastern US forward. So we're all in many ways moving over time. And I think that's an important thing. You've probably seen maps like this that show differences in life expectancy and show, unfortunately, as shown in the video, that place matters, right? And you'll note here there's about a 16 to 20-year difference in life expectancy in the US, depending on where you live. I'm going to show at the end data from Chicago. And in Chicago, unfortunately, within the city of Chicago, depending on where you live, there's that same 20-year gradient in life expectancy. That's what we all need to change. And I think it's within your power to do that. I want to spend a little bit of time also talking about disaggregating of data. particularly data on with race and ethnicity. And I think all too often we treat different groups as homogeneous groups, and they're not really that way. And we need to get better at disentangling some of that work. This is some of the work. I don't know if any of you worked with Tim Cunningham, but Tim was an amazing epidemiologist at the Centers for Disease Control and Prevention. His life was cut short too quickly, but worked with us to do a project looking at the prevalence of chronic conditions among Hispanic subpopulations, and was one of the first really at CDC to really look and document the differences by different subgroups. So when we combine all groups into to Hispanic Americans, we're really doing a disservice, and we really need to think about sort of doing more in terms of disaggregation. And then one of my other papers that I love, that was really a really formative piece of work for me, was a project that I did when I was at the University of Maryland, which was looking at the NHANES epi follow-up study, which is a national cohort study. And we were looking at the incidence of stroke. And I was interested in looking at Black-white differences in stroke incidence. Particularly here for this project, we looked at cerebral infarction. And what we found was we stratified the data by age. And so we looked at people who were over the age of 65 as one group, and people who were 35 to 64 as the other group. And then we adjusted for different factors in the analysis. And when you looked at the people who were over the age of 65 and above, there was essentially no difference in incidence of strokes between Blacks and whites. The disparity was gone. And you can see here in the model, the shaded circle is the crude model. The white circle is age and gender adjusted. The open square is age, gender, and education. And then the black square is basically everything in the model. So age, gender, education, hypertension, diabetes, heart disease, etc. And what you see basically over 65, there's no differences. But when you look at people who are 35 to 64 years of age, you see there's about a 2.4 times the increase risk of stroke, cerebral infarction. In the crude model, it goes down to about a 1.6 risk in the fully adjusted model. But it shows that among younger Black people, that's where there's this increased risk of stroke. This was published, I think, in the early 1990s. And then I go back to Tim Cunningham and the work that he did. This was on a CDC publication they called The Vital Signs, but really was looking again at Black-white differences in the incidence of stroke. I'm sorry, no, this is Black-white differences in death rates. And what I want you to take home from this is that in the early 2000s, among people who were over the age of 65, Blacks had a higher rate of death compared to their white counterparts. But over time, that Black-white disparity among people over age 65 has virtually disappeared. But in the younger age groups, that's where you see the disparity. And I think we can all think about what is it that's happened over time, particularly, for people who are over the age of 65, so that disparity has gone away. And I think one of the things that has happened over time is when you think about Medicare and Medicaid, the creation of Medicare in the 1960s and the impact that can have on older adults. But we don't have those same programs available for younger people and younger communities as well, but it illustrates the disparity. And when we look at sort of what he looked also in that publication on sort of where are the differences, the causes of black-white differences, right? It's heart disease, cancer, homicide, diabetes, et cetera. All things that in many ways I've been hearing about during the conference this morning. So it's really great to see this synergy there. I also wanted to make sure you all were aware the Office of Management and Budget, which is the group that decides how we collect race in the US, is thinking about sort of how they might change the way we collect race information. And so you may know that basically the way we collect race information, and we've been doing it this way since 1997, is we have two questions on race. We ask people if you're Hispanic or not. And then we ask people, and that's the ethnicity question. And then we ask people what race group they are, and they can select more than one. And since 1997, they've been able to select more than one race group. What they are proposing to do, and this is open for comment, is they're proposing to combine those two questions into one question. And people could check more than one race or not. So the white, Hispanic, et cetera. The other important thing that they are proposing is that there would be a new race category in the US, which would be Middle Eastern or North American. And that would be a new race category. Currently, those individuals are characterized as white in national surveys. The other thing, which I think is particularly interesting that the OMB is thinking about, is that in all of their surveys, and I think this will cascade into other surveys as well, is that they are, in fact, in addition to doing the usual race and ethnicity categories, are also going to add information and ask about racial and ethnic subgroups. And so they've sort of proposed a list of sort of what those subgroups might be. But in any event, this is up for public comment. And if you have feelings or ideas about sort of how we should do this as a country, I would encourage you to comment and send comments to the Office of Management and Budget. I want to now transition and talk a little bit about trauma and the impact that trauma may have. And one of the things that I was able to do at CDC was work with two amazing individuals, Rob Anda and Vince Folletti, who is at Kaiser Permanente. And we created, through that work, the Adverse Childhood Experiences Study, which looks at different types of abuse, neglect, and household dysfunction. And we created a series of questions that look at different levels of what we call ACEs. And it turns out, number one, that a lot of people suffer from adverse childhood experiences. Most Americans have between 2 to 3 adverse childhood experiences. But the other thing that I think is important is that we have found a very graded relationship between the number of adverse childhood experiences and a number of conditions. So chronic obstructive pulmonary disease, diabetes, heart disease, stroke, et cetera. We also find when you look at a number of risk factors, binge drinking, cigarette smoking, et cetera, you also see this strong graded relationship between adverse childhood experiences and those conditions. Back in time a little bit and talk about sort of community-based interventions, because when I was at CDC, we were doing all of this research and I was asking and became compelled to think about what do we do about it. And at the same time, Bill Clinton was president of the US. And he had this initiative called the Race Initiative, which was really to address inequities in race and address disparities. And John Hope Franklin led the whole Race Initiative activity. And all of the HHS agencies had a role and had to write reports around this. And in HHS, the decision was made that we would focus on cardiovascular disease, cancer, diabetes, immunization, HIV, AIDS, and breast and cervical cancer. And David Satcher had been director of CDC, and he then became Surgeon General. And so he was the one who was in charge of this whole race initiative. And he decided that there was going to be a community intervention. And he said that community intervention would come to the CDC because he had been director of the CDC. So he said, we'll just give it to CDC. And it came to my division, which was awesome. And so I got to sort of think about sort of how do we plan. And as Dr. Fouad mentioned, that we created this whole logic model and all that other great stuff. But one of the things we decided was we said, we're going to let communities be in charge. And so we said they needed to be a coalition. And that coalition needed to include an academic institution, a local or state health department, and a community-based organization. They all needed to come together. They would decide who would lead this effort. They would decide the race ethnic group that they wanted to target. And they would decide what the geographic boundaries were for that group. And they were pretty much in control. And we did a 1 year planning. It was supposed to be a 1 year planning, but probably was about 8 months of planning. And then they recompeted, and we funded 40 communities across the country. And most focused on cardiovascular disease and diabetes, but UAB chose to focus on breast and cervical cancer. A lot of them did disease management, risk factor control, screening, and almost all of them used some sort of component related to community health workers, which was really where I learned a huge amount about sort of the power of community health workers to work with communities. This is one of the early maps we had, which shows the 40 communities that were funded, UAB being one of the early pioneers. And my own institution, UIC, was also funded at the time as well. I'm just going to go through these pretty quickly. And then this is just sort of a little bit of this is from one of the community interventions, Bronx Reach, which went in the early 2000s focused on children's wellness. And focused on public schools in the Bronx, and was instrumental in changing the quality of food in the public schools in the Bronx. And it was actually that work that led all of New York City to lead and push for healthier food options for students. But what I loved about this was here were examples of where local community-based organizations came together, decided what to do, and then that work got scaled up by the health department, which was really extremely powerful. I think when I was at CDC, we used to use the term focus as we described reach. And particularly as it relates to the partnership with community-based organizations, we felt very strongly, number one, that there needed to be adequate funding, particularly for those CBOs. But frequently what would happen was funding would go to the health department or whoever had the lead, and very little would go out to help support community-based organizations. And we really felt strongly that dynamic needed to change. That really, when you're thinking about how you work with communities, that you need to be working with communities and community-based organizations that are trusted, that are embedded in the community, that come from the community as well. I'll talk about this again when I go to the next section. But as I think about the conversations that we had across the country as part of the REACH experience, I was struck by how the community-based organizations in many ways drove the types of interventions. They knew what would work in their local community, and just embracing that and lifting that up, I think, is really important. Going back to this, my comments early about trauma, really addressing some of those underlying factors or underlying conditions that are causing these disparities is really important. And then finally, thinking about sustainability, and thinking about sustainability from day one. And what I loved during my visit here to UAB, it's been really cool to see how you have, in fact, been able to sustain those community-based activities and interventions that have occurred and really build on that, particularly as you're training the next generation of researchers. And that, for me, is really exciting. So I want to transition now, and all this will come together in just a minute, but talk about the importance of hyperlocal data. So I'm going to ask a question to the audience, and we'll see, does anybody know who this gentleman is? And I'm probably dating myself a little bit, but anyone know who it is? I'm sorry? No? Yeah, there you go. It's Tip O'Neill. And Tip O'Neill is from Boston, and he was Speaker of the House for many, many years. And, we now talk about the legacy of Nancy Pelosi and how great she was. But Tip O'Neill was an amazing individual. And he would always say, all politics are local. And as I think about our work, I've tweaked it a little bit, and I say all public health is local. And so it's really important that we provide data and information in a local fashion. And so for the last couple of years, we have been running out of the School of Public Health, in collaboration with the Chicago Health Department, the Chicago Health Atlas. And there are a couple of things about this photo here. Most photos that you see of the city of Chicago are taken from the north looking south. And they do that, you can, I'm going to stop there. So, and they do that, I will say they do that so that you will see the coastline of the lake, which is beautiful. But this photo here is from the west side of Chicago, which you rarely see pictures from. West side of Chicago is where a lot of the Black and brown community in Chicago resides. And so as we were creating the atlas, we said the photo and the grounding is going to be from the west side of Chicago. So the atlas provides data to local community members, researchers, our students in the School of Public Health, and anyone who wants it, at multiple levels. So you can get data at the census tract level, at the zip code level, at the community level. We talk about 77 community areas in Chicago, and that's what you're seeing here on this slide. And I should mention, just to orient you on this, sort of the large gray area on the right is Lake Michigan, and then sort of north is up, then south is down, and to the west is the western parts of the city. And one of the things, so this is looking at COVID case rates. This was from early 2020, right? And I think when, as you look at this, I should mention the darker the color, the higher the rate. And that's going to be the truth for all of the maps that I will share with you today. But you'll note that basically when you're looking at Chicago, what you'll see is basically if you're looking west, you'll see higher rates of COVID. And if you look south, you'll see higher rates of COVID. And that, again, is where the Black and brown communities tend to reside. And particularly if you go north, and particularly if you go what I call near north, which not all the way up to the city border north, again, you'll see lower rates of disease. But it's not, and this is looking at COVID death rates, right? But a very similar picture. And I think you can think about sort of what's happening in each of these communities that might be leading to what we're seeing and why we're seeing what's on the map. But, right, it's not just COVID where we see this. But if I look at heart disease, I'm going to see a map that's pretty similar with that north or near north area of the city having much lower rates of heart disease than other parts of the city. Or I can look at diabetes, right? And you see a very similar picture with diabetes. And you could argue, well, we know that diabetes and heart disease are risk factors for COVID mortality. So that's why we're seeing the higher rates of COVID and COVID mortality in these communities as well. If we look at hypertension, we see a very similar picture as well with higher rates of hypertension in the south and western parts of the city. When we look at obesity, we see the same thing that's going on. This is looking at adults who smoke one or every day or most days in the last month. And again, higher rates of smoking. As I think about, the price of cigarettes today is unreal. And I think about someone who's purchasing cigarettes. And you think about Chicago in the winter, where it might be 10 or 20 degrees below zero. And you have someone who's going outside to smoke a cigarette. I got to think what is going on in that individual's mind, right? I mean, are they self-medicating in some way for something? And I think we need to be thinking about what is it? Why are they, what is it that's leading them to do this? What about the disease? What about the addiction that is leading them? And thinking about sort of what those underlying factors. This is participating in physical activity, or this is not participating in physical activity or exercise over the last month. And again, higher rates of not participating in physical activity is much higher on the south or west side. Mona and I, after dinner, were talking, and there was a gentleman who was riding his bike down the street, and we were talking about bike lanes and the importance of bike lanes. One of the things that I was struck by in moving to Chicago is we have some communities who have bike lanes and other communities that don't have bike lanes. We have these they call them divvy stations, but they're stations where you can go to rent a bike. Those divvy stations are much more prevalent on the northern parts of the city than they are on the southern and western parts of the city. Cities making efforts to change that, but it's pretty striking when you look at sort of where the divvy stations went initially. And then you sit there and you look at something like this, looking at physical activity. This is looking at sugar sweetened beverage consumption. And again, sort of the same communities being impacted over and over again. This is looking at low food access. So this means having a grocery store within half a mile of where you live. And again, low food acts much more than the South and West Side. I will tell you that over the last month, Whole Foods and Walmart have all closed, or actually tomorrow, Walmart will be closing 3 locations on the south side of Chicago. So this food access issue is going to get even worse than it was. And Whole Foods closed. You know, they all these supermarkets came in with this huge fanfare, you know, and everyone was so excited. And then 4 or 5 years later, they're closing and moving out. And they're saying the stores are not profitable. This is living in poverty. So again, sort of what you see in terms of higher rates on the north, lower rates on the north parts of the city. And then this is looking fine. The last one I'm going to show you before I pivot back in a minute is unemployment. And so higher rates of unemployment in these communities. And so many ways, these communities have also suffered from disinvestment. So I said earlier, the darker the color, the higher the rate or the number. And so this is looking at life expectancy. So basically now what you're seeing is the reverse of all of those other maps. So longer life expectancy is on the north part of the city, lower life expectancy to the south and west. And when you look across, it is about a 15-year difference in life expectancy, depending on where you live across the city of Chicago. So similar to what that national trend showed as well. So I've been giving you a whole bunch of, you know, somewhat depressing information. And in some ways, I apologize for that, but I'm doing it for a reason, because I want you to also understand something that we can do about all of that. So this is COVID vaccination rates, and this is in early 2020. And right, I bet you most of you would say, well, this is what I would expect we would see, that there'd be lower vaccination rates on the south side and on the west side of the city. But one of the things that the city decided to do was they created a coalition that included community-based organizations, academic institutions, the health department, and the mayor's office. The mayor called it the Racial Equity Rapid Response Team. And so we met on a weekly basis. And we were all focused on what we could do around vaccine hesitancy. And so every Friday afternoon, I should also mention the mayor decided to divide the city up into 6 racial ethnic equity zones. And there was a community-based organization that had the lead for each of those. And then they had an academic partner as part of it as well. And every Friday afternoon, we met and we provided those community-based organizations with the data on where the lowest rates of vaccine uptake were in their community. And then they went literally, as shown here in the picture. This is on a Saturday morning where everyone's meeting in a parking lot. This is in the Belmont-Cragen area, the community. But basically, people went out, mobilized, and literally went door to door, talking about the importance of vaccines and getting people to get people vaccinated, and also talking about, and also making sure that people didn't have to travel very far to get vaccine. So whether it was a local school that was a vaccine site or a supermarket or whatever, all of those were sort of opportunity for vaccinations. And this was April 4th, 2023. And so what was about a 40% difference in vaccine ended up being about a 10%, 10 to 15% difference in vaccines. So a huge improvement from what we had initially. And then this is just looking at the data by a race and ethnic group. And so you can see for the Latinx population and the white population, essentially no different being complete in terms of vaccine. For the Black community, it's about a 13% lower, but not nearly what it was earlier on. And to me, that is the power of sharing information, sharing data with community-based groups, helping them to take action and being able to mobilize for equity. So with that, my last slide is one of my favorite quotes from James Baldwin. It is, "I know that what I am asking is impossible, but in our time, as in every time, the impossible is the least one can demand. Everything now we must assume is in our hands. Do not falter in our duty now. We may be able, handful that we are, to end the racial nightmare and achieve in our country and change the history of our world. This is our time. We can make equity a reality." Thank you very much. Do we have time? Do you want to do questions? Yeah.
Dean Giles, thank you very much. Paul Irwin, your UAB. The last slides that you showed, the achievements with the vaccine coalition, the rapid response group, have you been able to take that work and focus it on some of the other things that you showed, such as cardiovascular disease?
No, I think sort of that is sort of our next step. I think, we've shown that, we can use this model for COVID and COVID vaccines, but I would love to, and sort of where we want to go is sort of thinking about things like hypertension control or diabetes, et cetera, but sort of, bringing that coalition together, having hyperlocal data and target, because I do think that's sort of a real opportunity. Yeah, so thanks. Yeah, we're on the same page there. Yeah, very good. Any other questions? Sure.
So I'm just going to follow again with Dr. Irwin, because it seems like when there is a will and intention, we can make a change. And a lot of us, the leader, been trying to work on health equity for a long time, but we feel like we're going in circles. But when COVID happened, this became like urgency and risk, and people like just got out of the box. Even NIH did the same thing. CDC did the same thing. Everybody, like every city. How can we make inequity in health and health disparities is also like give it the urgency that you showed that the gap in survivorship, like 15 years lifespan, people are dying. It's not like, maybe if you look at the numbers, you're going to see even higher than people died from COVID. So how can we do that? Because that mobilized, COVID mobilized people and got them to come together. There was a scare, there was an urgency, but nobody seems to really much move, and we got used to, there's a difference in hypertension and mortality and cancer and obesity, but we're not doing anything.
So I think there are a couple of things so number one, and I'm going to go back, I'm going to tell another REACH story. And this was from MUSC in South Carolina. And they were doing a whole series of focus groups. in their community, and they were in Charleston. And so they were talking with community members about, they were focused on diabetes and particularly amputations that were happening because of diabetes. And as they were talking with community groups, the communities thought, well, this is what happens with everyone when they get amputations, et cetera. And as they talked about sort of, no, this doesn't happen with everybody. There was an awareness that occurred. And I do think, and I heard it earlier today, as we do a better job of, democratizing data, making information available to communities, I think that awareness, we can use to help mobilize people. And I will say, I will say as part of COVID, community members were used to sort of going to the dashboard every single day and looking to see what the COVID rates were. And I think, and they wanted to know what was going on in their community, et cetera. And so I do think, making sure people are aware of what's going on in their community and saying that it doesn't have to be this way, I think is important. The other thing I will say about COVID is I do think it has I think there was a little bit of complacency, which I'm hoping that has stopped. And that people will begin to, really mobilize and say they want real change. And so I think that to me is sort of the other sort of important opportunity with COVID.